Mantle cell lymphoma is one of the rarest of the non-Hodgkin's lymphomas, comprising about 6% of NHL cases. There are only about 15,000 patients presently in the US. MCL is difficult to treat and seldom considered cured. Median survival times were about 3 years, but are now estimated as approaching 6 years for new patients. MCL is a subtype of B-cell lymphoma, due to CD5-positive antigen-naive pregerminal center B-cell within the mantle zone that surrounds normal germinal center follicles. MCL cells generally overexpress cyclin D1 due to AT1114 chromosomal translocation in the DNA. More specifically, the translocation is at T11, 14, Q13, Q32. Symptoms: at diagnosis, patients typically are in their 60s and present to their physician with advanced disease. About half have either fever, night sweats, or unexplained weight loss. Enlarged lymph nodes or splenomegaly are usually present. Bone marrow, liver and GI tract involvement occurs relatively early in the course of the disease. Pathogenesis, MCL, like most malignancies, results from the acquisition of a combination of genetic mutations in somatic cells. This leads to a clonal expansion of malignant B lymphocytes. The factors that initiate the genetic alterations are typically not identifiable, and usually occur in people with no particular risk factors for lymphoma development. Because it is an acquired genetic disorder, MCL is neither communicable nor inheritable. A defining characteristic of MCL is mutation and overexpression of cyclin D1, a cell cycle gene, that contributes to the abnormal proliferation of the malignant cells. MCL cells may also be resistant to drug-induced apoptosis, making them harder to cure with chemotherapy or radiation. Cells affected by MCL proliferate in a nodular or diffuse pattern with two main cytologic variants, typical or blastic. Typical cases are small to intermediate-sized cells with irregular nuclei. Blastic variants have intermediate to large-sized cells with finely dispersed chromatin and are more aggressive in nature. The tumor cells accumulate in the lymphoid system, including lymph nodes and the spleen, with non-useful cells eventually rendering the system dysfunctional. MCL may also replace normal cells in the bone marrow, which impairs normal blood cell production. Diagnosis: diagnosis generally requires stained slides of a surgically removed part of a lymph node. Other methods are also commonly used, including cytogenetics and fluorescence in situ hybridization. Polymerase chain reaction and CER3 clonotypic primers are additional methods, but are less often used. The immunophenotype profile consists of CD5+, CD10/+, it is usually CD5+ and CD10. CD20+, CD23/+. Generally, cyclin D1 is expressed but it may not be required. The workup for mantle cell lymphoma is similar to the workup for many indolent lymphomas and certain aggressive lymphomas. Mantle cell lymphoma is a systemic disease with frequent involvement of the bone marrow and gastrointestinal tract. There is also a not uncommon leukemic phase, marked by presence in the blood. For this reason, both the peripheral blood and bone marrow are evaluated for the presence of malignant cells. Chest, abdominal, and pelvic CT scans are routinely performed. Since mantle cell lymphoma may present a lymphomatous polyposis coli and colon involvement is common, colonoscopy is now considered a routine part of the evaluation. Upper endoscopy and neck CT scan may be helpful in selected cases. In some patients with the blastic variant, lumbar puncture is done to evaluate the spinal fluid for involvement. Key diagnostics for MCL: CT scan, computerized tomography scan yields images of part or whole body. Gives a large number of slices on X-ray image. PET scan, generally of the whole body, shows a three-dimensional image of where previously injected radioactive glucose is metabolized at a rapid rate. Faster than average metabolism shows as a black area and indicates that cancer is likely present. Metabolism of radioactive glucose may give a false positive, particularly if the patient has exercised before the test. PET scans are much more effective when the information from them is integrated with that from a CT scan to show more precisely where the cancer activity is located and to more accurately measure the size of tumors. Prognosis: the overall 5-year survival rate for MCL is generally 50% to 70%. Prognosis for individuals with MCL is problematic and indexes do not work as well due to patients presenting with advanced stage disease. Staging is used but is not very informative, since the malignant B cells can travel freely through the lymphatic system and therefore most patients are at stage 3 or 4 at diagnosis. Prognosis is not strongly affected by staging in MCL and the concept of metastasis does not really apply. The Mantle cell lymphoma International Prognostic Index was derived from a data set of 455 advanced stage MCL patients treated in series of clinical trials in Germany, Europe. Of the evaluable population, approximately 18% were treated with high-dose therapy and stem cell transplantation in first remission. The MIPI is able to classify patients into 3 risk groups: low risk, intermediate risk and high risk. In addition to the 4 independent prognostic factors included in the model, the cell proliferation index was also shown to have additional prognostic relevance. When the Ki-67 is available, a biologic MIPI can be calculated. MCL is one of the few NHLs that can cross the boundary into the brain, yet it can be treated in that event. There are a number of prognostic indicators that have been studied. There is not universal agreement on their importance or usefulness in prognosis. Ki-67 is an indicator of how fast cells mature and is expressed in a range from about 10% to 90%. The lower the percentage, the lower the speed of maturity, and the more indolent the disease. Katzenberger al. Blood 2006. 107-3407 graph survival versus time for subsets of patients with varying Ki-67 indices. He shows median survival times of about 1 year for 61 to 90% Ki-67 and nearly 4 years for 5 to 20% Ki-67 index. MCL cell types can aid in prognosis in a subjective way. Blastic is a larger cell type. Diffuse is spread through the node. Nodular are small groups of collected cells spread through the node. Diffuse and nodular are similar in behavior. Blastic is faster growing and it is harder to get long remissions. Some thought is that given a long time, some non-blastic MCL transforms to blastic. Although survival of most blastic patients is shorter, some data shows that 25% of blastic MCL patients survive to 5 years. That is longer than diffuse type and almost as long as nodular. Beta-2 microglobulin is another risk factor in MCL used primarily for transplant patients. Values less than 3 have yielded 95% overall survival to 6 years for auto-SCT, where over 3 yields a median of 44 months overall survival for auto-SCT. This is not yet fully validated. Testing for high levels of LDH in NHL patients is useful because LDH is released when body tissues break down for any reason. While it cannot be used as a sole means of diagnosing NHL, it is a surrogate for tracking tumor burden in those diagnosed by other means. The normal range is approximately 100 to 190. Treatments: there are no proven standards of treatment for MCL, and there is no consensus among specialists on how to treat it optimally. Many regimens are available and often get good response rates, but patients almost always get disease progression after chemotherapy. Each relapse is typically more difficult to treat, and relapse is generally faster. Fortunately, regimens are available that will treat relapse, and new approaches are under test. Because of the aforementioned factors, many MCL patients enroll in clinical trials to get the latest treatments. There are 4 classes of treatments currently in general use: chemotherapy, immune-based therapy, radioimmunotherapy and new biologic agents. The phases of treatment are generally, frontline, following diagnosis, consolidation, after frontline response, and relapse. Relapse is usually experienced multiple times. Chemotherapy: chemotherapy is widely used as frontline treatment, and often is not repeated in relapse due to side effects. Alternate chemotherapy is sometimes used at first relapse. For frontline treatment, CHOP with rituximab is the most common chemotherapy, and often given as outpatient by 4. A stronger chemotherapy with greater side effects is hyper-CVAD, often given as inpatient, with rituximab and generally to fitter patients. Hyper-CVAD is becoming popular and showing promising results, especially with rituximab. It can be used on some elderly patients, but seems only beneficial when the baseline beta 2 mg blood test was normal. It is showing better complete remissions and progression-free survival than CHOP regimens. Another chemotherapy class is fludarabine monotherapy, sometimes combined with cyclophosphamide and mitoxantrone, usually with rituximab. Cladribine and clofurabine are 2 other drugs being investigated in MCL. Cytotoxic chemotherapies, including bendamustine, are being studied alone and with similar combinations. A relatively new regimen that uses old drugs is PEPC, which includes relatively small, daily doses of prednisone, etoposide, procarbazine, and cyclophosphamide, taken orally, has proven effective for relapsed patients. According to John Leonard MD, a key researcher proponent of PEPC, may have anti-angiogenic properties, something that he and his colleagues are testing through an ongoing drug trial. Another approach involves using very high doses of chemotherapy, sometimes combined with total body irradiation, in an attempt to destroy all evidence of the disease. The downside to this is the destruction of the patient's entire immune system as well, requiring rescue by transplantation of a new immune system, using either one's own previously treated and stored stem cells, or those from a matched donor. A presentation at the December 2007 American Society of Hematology conference by Christian Geisler, chairman of the Nordic Lymphoma Group, claimed that according to trial results, mantle cell lymphoma is potentially curable with very intensive chemoimmunotherapy followed by a stem cell transplant, when treated upon first presentation of the disease. These results seem to be confirmed by a large trial of the European Mantle Cell Lymphoma Network indicating that induction regimens containing monoclonal antibodies and high-dose ARAC followed by ASCT should become the new standard of care of MCL patients up to approximately 65 years. A study released in April 2013 showed that patients with previously untreated indolent lymphoma, bendamustine plus rituximab can be considered as a preferred first-line treatment approach to a CHOP because of increased progression-free survival and fewer toxic effects. Immunotherapy. Immune-based therapy is dominated by the use of the rituximab monoclonal antibody, sold under the trade name Rituxan. Rituximab may have good activity against MCL as a single agent, but it is typically given in combination with chemotherapies, which prolongs response duration. There are new variations on monoclonal antibodies combined with radioactive molecules known as radioimmunotherapy. These include Zevalin and Bexxor. Rituximab has also been used in small numbers of patients in combination with thalidomide with some effect. In contrast to these antibody-based passive immunotherapies, the field of active immunotherapy tries to activate a patient's immune system to specifically eliminate their own tumor cells. Examples of active immunotherapy include cancer vaccines, adoptive cell transfer, and immunotransplant, which combines vaccination and autologous stem cell transplant. Though no active immunotherapies are currently a standard of care, numerous clinical trials are ongoing. Targeted therapy. In November 2013 ibrutinib was approved by the US FDA for treating MCL. Other targeted agents include the proteasome inhibitor bortezomib, mTOR inhibitors such as temsirolimus, and the P110I inhibitor GS1101. Epidemiology. Of all cancers involving the same class of blood cell, 6% of cases are mantle cell lymphoma. The ratio of males to females affected is about 4:1. See also, List of hematologic conditions, references. External links, a brief review of the biology and pathophysiology of mantle cell lymphoma, Mantle Cell Lymphoma Consortium, Lymphoma Association, a Euro-specialist UK charity providing free information and support to patients, their families, friends and carers.